Perfect. Hi, everybody. I'm very excited to be with you all today. I'm Sam Cotton. I'm an associate professor at the University of Louisville School of Medicine, and I'm actually a social worker. And one of my roles at the University of Louisville is we have a geriatric workforce enhancement program grant funded through HRSA, and I am our director of Alzheimer's disease and dementia-friendly communities initiatives through that particular grant. One of the things that I've spent really my career doing is working with persons with all types of dementia in both community and nursing home settings. And so as I talk through our topic today, I'm going to draw on some of those experiences. As Lindsay said, I do have I actually have two case studies that are sort of composites of people that I have worked with across the work that I've done in Kentucky. And I'm hopeful that both of those situations that I share with you will be very helpful in terms of understanding more about this particular topic. So, as we all know, today's session is called When Safety is Compromised, Dementia-Informed Responses to Sexual Assault and Other Forms of Abuse. And I really want to, given my background in the field as a social worker, really start at this from a two-directional problem. Most of us are really used to thinking about people with dementia as potential victims of abuse, whether it be sexual abuse or other forms of abuse. And we're going to spend some real time there talking about some of those challenges and some of those issues that one might encounter. But I also think there's a very second, very can be more difficult in some ways direction that we also need to take this conversation. And that is when a person with dementia is the one whose behavior really causes the harm to others, whether that be other residents in a nursing facility or staff or in the community setting as well, family, friends, that kind of situation that might come up. So we're going to hold both of these sort of challenges that can happen in the same space today because in practice, they often show up in the same room, as I found time and time again in my own practice. So that's going to be the nature of our overarching sort of conversation today. So Lindsay, you can go to the next slide. And before we go further, I want to sort of highlight that this is heavy material we're talking about. We're talking about sexual assault, abuse, trauma involving people who are among the most vulnerable that we might be caring for. And so for some of us, in addition to sort of that professional hat where we might have dealt with this before, there's also that personal response that we might have to some of this material as well. So if you need to step away for a bit, please do. I'm going to try and keep this very practical, compassionate, not graphic. And you'll see that in the two case studies that I present to you today as part of this didactic. These are sort of composites of very real people I've worked with, but I've completely de-identified everything and kept it again from to help you better understand more of the practical nature of what we're talking about. And then the other thing I want to be very upfront about, and I was telling some people from the panel this earlier, is the evidence about sexual abuse in the population of working with persons with Alzheimer's disease and related dementias. It's very slim, unfortunately. The research on people with dementias as victims in these particular situations is growing, but the research on what to do when the person with dementia is causing the sexual harm is much thinner than even that. So we sometimes often see small sample sizes, little consensus about what to do in certain situations. And in some situations as well, when we start thinking about treatment in these settings, that, we draw upon our evidence-based practices that we already know related to working with persons with dementia. So today I'm going to lean in on clinical judgment, lean in on ethics, some care principles that might seem very familiar to a lot of you. And I'll try to note that where I can, where we do have research in this particular piece, and in some places that we don't. So I hope at the end as well, we'll have ample opportunity for us to have a larger discussion about this because I'm assuming that some of you have had similar experiences in your work with persons with dementia as well. Next slide, please. So here's the shape of the problem when we talk about sexual abuse and dementia. On one side, we have the person with dementia as a victim. We know there's higher risk for this to happen. Often there's lower detection. And partly this is due to the fact that cognitive impairment really blocks disclosure. Individuals aren't always able to articulate or communicate what's going on with them. And often, what that translates to is it undermines the credibility of maybe individuals who are observing the behavior or even what that person can report to us. So often we see that the abuse goes unreported, unseen, unfortunately, in some situations. And so that's one piece of the problem that we're talking about when we talk about sexual abuse. On the other side, we have the person with dementia whose behavior might be causing harm. We have individuals who are dealing with behaviors where maybe they're dealing with, uh, you know, they're not necessarily able to identify that they are doing something wrong or harmful to somebody else. And sometimes this can really manifest as sexually inappropriate behavior, and it doesn't necessarily come from this sort of idea of criminal intent, right? As the law would usually mean when we're talking about sexual abuse. So that is in and of itself a very difficult position for those of you who might be practitioners or providers out in the community working and or working in nursing facilities. We do have a few numbers to anchor us in terms of the scope of this problem. One is a 2023 meta-analysis that used 30 studies, and it found that about 43% of people with dementia experience abuse. Now, psychological abuse is the most common, but we have to also underscore that, when we start talking about abuse in general, some of that could be sexual abuse. And then when it comes to reporting, only about 13% of abuse victims with dementia ever report. And then if you compare that to 62% of persons without dementia who report, you can see sort of the stark divide here between some of the layers or complexity that dementia adds to this problem. There was a study that was done in 2006, which I know is, not that recent at this juncture in time, but it is one of the most comprehensive studies, and it looked at elder abuse and sexual abuse specific cases and found that roughly 6 in 10 victims had dementia or another cognitive impairment. So, in thinking about this from sort of this standpoint, we see that the scope of this problem is pretty stark, right? And as I've already mentioned, there's not a significant body of evidence or research being poured into this. Next slide, please. So today, as part of our sort of lens or focus, I'm hoping that, by the end of our didactic and our conversation today, that one, you'll be able to recognize the behavioral indicators of abuse, especially in those situations when somebody can't verbally disclose what's going on with them, that you'll be able to respond in a more appropriate or evidence-based way using dementia and trauma-informed strategies. And I point to those because, when we're talking about persons with dementia, we can't focus on interventions that are narrative focused or focus on that memory piece because largely for persons with dementia, we're not going to be able to use strategies that rely heavily on that. And then last but not least, really thinking about how to manage those harmful behaviors by a person with dementia in a way that's compassionate, that really protects their dignity and respects them, but also understanding that that behavior has a true impact on those around them. Next slide, please. So I'm going to start by telling you about Margaret. Again, not her real name. But this is a person that I worked with out in the community, and in particular, because of some of the work that I do with caregivers, I had worked with her adult son, who was her primary caregiver at the time. Now, at the time of this particular situation, Margaret had moderate Alzheimer's disease, and she lived at home with her adult son, and he was her primary caregiver. As part of the work that our team was doing with her, I was sort of involved in a number of different conversations about Margaret's care. Uh, and as part of this, we were also involved with the home health agency that was working with Margaret as well. So they were going in and providing some of that direct care to her. At some juncture during the course of Margaret's care, one of the home health aides who was, I would say, more consistent person in her life was noticing some very stark changes in her behavior. She first noticed that she had begun to cry and become more resistant during the personal care experience. Then she also noticed that there had been some bruising on Margaret's inner thighs, very new, right? And then had overheard a discussion where a family friend was supposed to be coming to visit. And when that person's name was mentioned, Margaret had a very intense reaction to that, screaming, "Don't let him in. I don't want to see him," becoming very visibly agitated and upset. And when asked directly, she couldn't describe any particular event that had occurred. And then moments later, when the aide was talking to her, really didn't even remember the conversation had happened. So I present to you this kind of piece, and I'll share with you what ended up happening here in a bit. But think about what you first notice in this sort of scenario. One, it's the nurse aide who's really sort of noticing these things, sort of as that part of the care group. Providing the individuals providing care to Margaret, but not necessarily in that sort of family bubble, right, or that friend bubble. And so I also want to acknowledge as well, from my perspective as a practitioner, sort of coming into this setting and sort of observing all of these different things happening. What made it harder for me was that this is potentially a situation that's happening in the home, not in a facility as well. And if you can go ahead and go to the next slide, I'm going to talk about some of these reasons why this becomes more difficult and things we should be looking at. And I'll also share with you what ended up happening with Margaret and what was occurring. So sometimes when words fail, we have to really use behavior as sort of that disclosure of something's going on. And this is where we really have to lean into our clinical judgment. And where training and experience really sometimes comes into play. So when somebody can't give you a narrative, their behavior really becomes that disclosure sometimes. And so these are some things to look at. Um, First, obviously, physical signs that somebody is being abused. So we might have unexplained bruising, especially in the inner thighs, the breasts, the genital areas. They might be complaining of genital pain. And sometimes they might not necessarily be able to name it, but they might be pointing at a certain, area of their body and saying, "I have pain here." We might see new bleeding, um, things like torn or stained clothing. So those are all the physical signs that we should be looking at, in addition to sort of observing their behavior. We might often see that individuals also have care task reactions. So they might have this new fear of a certain setting, like, for example, bathing or toileting, things of that nature, where they are more vulnerable. We might see more crying or combativeness during these types of scenarios as well. The other thing to also keep in mind is if they're refusing care from one specific person and that is not something that has occurred before. We often see that individuals with dementia also, who are dealing with some of the trauma of sexual abuse, might have challenges related to mood swings, sleep, regression, nightmares, or a startled response when somebody is touching them or coming up from behind, agitation, or significant decline very quickly. And then we have the relational clues that are often at play as well that we have to consider. So distress that's often tied to a specific person or place or a specific time of day. In the community as well, even if a family member is a caregiver of that individual, we also have to consider, do we have a caregiver here who hovers over every little task that that person's doing, or tries to isolate them or answer for them in certain situations. Now, I understand by talking about all four of these different areas that you might be sitting here thinking, how do you determine what is the dementia and that what that person needs and what might be going on with them versus what could be some of these behaviors. And what I always say is that one, in these scenarios, it's really important for you to know the change from baseline. And obviously, with a person with dementia, we do expect there to be decline and change from that baseline. But a lot of times, when we see these types of behaviors occurring very rapidly, like overnight or within a week, if you're looking at a specific time frame, that should alert us because largely these types of reactions that a person is having, if we want to attribute it back to dementia, it's going to be a little bit of a slower decline, unless they have something like pain or infection that are contributing factors as well. Regardless, those are things we need to investigate as well. So it's important for everyone who's part of that person's care to really understand what that person's baseline looks like. Next slide, please. The other thing that I think is important to note when we talk about sexual abuse is that a lot of times this does go undetected and unprosecuted and unreported. There's a couple of different reasons for that. One, it's important to note that when we talk about memory loss, that doesn't equal no trauma, right? Emotional and bodily memory persist long after narrative memory fades. The body's going to keep responding to those situations where that person might be re-traumatized. Regardless of that, they might not be able to, again, verbally articulate that. So that's why it's so important for us to pay attention to some of those cues. I think largely when we talk about persons with dementia, part of the issue as well is that they get sort of pegged as this unreliable witness. It might be fragmented what they're able to tell us or what they're able to communicate verbally. So a lot of times, even if they are able to tell us something, because it's fragmented or it's delayed, it often gets discounted. So individuals who have perpetrated these crimes are less likely to be arrested or charged, especially when the victim has dementia. There's also been some recent research into the concept of a ageist bias, especially when we talk about cases that do actually make it in front of a jury. Research on mock jurors found that a warm but incompetent view of older adults with dementia actually predicted their verdicts, meaning that, they felt compassion towards this person. They're an older adult, but they did not necessarily view them as a reliable narrator of their own life. And so therefore, they were less likely to convict the person again, even if it was brought to trial. And in one particular study, they found that those standard jury instructions that individuals are given, they didn't really correct for that. So that's a bias that sort of really impacts this whole process. Then, as I've already mentioned, symptoms sometimes get misattributed. So that fear, that agitation, sometimes those get logged as behaviors of dementia. Sometimes they get medicated, but they don't always get investigated. And so that becomes this sort of perpetual cycle for the individual. And then because individuals are not necessarily able to verbally communicate what happened, discovery is often delayed. So, if it was a sexual assault that a person faced, evidence degrades, forensic exams are delayed. And so that window sort of closes before even, anyone even suspects that something happened. And what I want to point out here is that the absence of a coherent story is not absence of assault. That's where we really need to, as providers, practitioners, jump in and sort of identify if we have sort of red flags going on with an individual that we're concerned about. Next slide, please. When you do suspect abuse, the first 24 to 72 hours really matter. First you want to make sure that person's safe. Especially if you suspect, based on everything you're observing, one person in particular is the abuser. Try to implement no unsupervised contact with that person in the meantime. Regardless, sometimes there's that investigation that has to happen to sort of clarify what actually happened. But making sure in the meantime that person's safe and address any urgent medical needs. Um, Two medical and forensic exams are very important. A prompt exam can really be helpful in these situations. Really requesting a sexual assault nurse examiner, or in some states they call that role something different. But really focusing on that, treating injuries, evaluating for, STIs or STDs, and then all of that really does need to get documented. And then third, reporting is so important. Obviously, this is mandated for all of us who are, practitioners out in the field. But in the community as well, I always encourage family, friends, individuals in the community who really suspect that something's going on with an individual, sexual abuse or just abuse in general, really to call Adult Protective Services. Largely in our nursing facilities, there are, sort of provisions in place for a lot of this as well. So it's a little bit more formal in that juncture. But in the community, we also really need individuals to pay attention to this. And then fourth, the thing that I always remind people is that it's important for us to document and not necessarily interrogate the individual. We want to record verbatim statements from the person, observed behavior, facts, not conclusions. Really minimize repeated questioning of the person with dementia, because sometimes what happens is, you might ask the same question and get different responses from the person with dementia. So really making sure that we're trying to minimize the potential for somebody from the outside to look at a situation and say, okay, well, there were inconsistencies in the statement. Because of course they're going to be, that person has dementia. So wherever their focus is at the moment is, going to be that. So really making sure that, we have a skilled somebody who's interviewing the person at the end of the day who's skilled in cognitive impairment and understands that and can document the totality of what that person is saying and what they're observing. Next slide, please. So I've mentioned several times that these sort of situations happening in the home is harder. Margaret, for example, community case for me that I worked with. So that really changes things. We know in the community there are fewer eyes. There's no ombudsman, there's no surveyors, there's no shift change that's occurring, there's not multiple staff involved usually. A home health aide or a primary care visit might be the only outside contact that person experiences. It has been some research to suggest that anywhere from 80 to 90% of all older adult sexual abuse happens in the home, which is exactly where it's least likely to be seen, right? So really important for us to focus in on how do we support those individuals living in the community. The abuser is often somebody known to that person and is often trusted, even maybe by the primary caregiver, right? A family member, a friend, sometimes a paid caregiver, unfortunately. Sometimes the abuser really dominates that care plan, right? That those of us who are working in the community might be focused on. They might control the door, they might control the phone, the finances, really the narrative around what's going on with that person. In the community, we really do rely on those reports to APS to sort of help with this, but APS also does really rely on partnerships to better understand what's going on. So, coordinating with medical services, safety planning. Sometimes this might mean emergency respite for the individual, especially if this is occurring in the home. Protective orders or guardianship, depending on the situation. So all of these different contexts, especially what I would call the boots on the ground, those critical, individuals who are really providing support to persons in the community, which is our direct care workers, like our aides or clinical staff who are, heavily involved. But this can also extend outside to other parts of a person's network or touch points they might have. Meal delivery, systems like Meals on Wheels, faith-based communities, neighbors who might be sort of, on the periphery, but seeing that something quite not quite right is going on with the person. And so they become sort of the support system as well. And they're truly so important in these specific situations. Next slide. So now, we've talked about some of the logistics when somebody's in the community about reporting, what to look at. Let's talk about the healing piece. Here's sort of the key idea. Traditional trauma therapy really assumes this sort of narrative therapy, right? Or this you being able to go into a therapeutic situation and share with somebody your narrative of what happened and sort of process and heal, that you can talk through it, right? When we start talking about healing in this space as it relates to dementia informed, trauma informed care, it really focuses on helping target this idea of feeling safe again, and not necessarily on that verbal processing that's often required when we talk about therapy. So we really want to help the person feel safe. That can be through consistent caregivers, a predictable routine, familiar objects, really thinking about the environment that that person's existing in and creating a space that is really soothing and calm. Safety for a person with dementia has to be experienced, not explained. Just telling them they're safe is not going to be helpful, right? Because they might not necessarily comprehend that in the same way they once were able to. We also want to adapt care so it's not triggering. So, bathing or perineal care, really making sure that we're mindful that that can reenact the assault that the person was dealing with. In some situations, depending on who was the abuser in the situation, same gender caregivers might be helpful. Making sure that we narrate before we touch the person, telling them, here's what we're going to do first. Here's what this is going to look like. Really seeking assent, making sure that they're, giving you sort of those physical cues that that is okay when you're helping them. And then pausing immediately when distress sort of, comes up if that happens. We also want to follow and not force, never push for, recall or try to connect those fragments with a person with dementia. Sometimes those sorts of interventions can be more harmful than helpful. We want to validate the emotion, not necessarily focus on the facts of what happened, but if that person's showing you distress, let's attend to that, right? Finding ways in which that person accepts comfort or derives comfort. So things like music or presence or appropriate touch, like a hand massage, for example, when it's welcomed. And the other thing I also, because of the nature of the work that I've done and the situations I've dealt with, sometimes the abuse that has occurred to the person with dementia, it doesn't just impact that person. We also have to think about those primary caregivers or those family members who might be affected by this because it's happened to their loved one. So we need to think about it from, their secondary trauma from being involved in this, and maybe some of the anxiety that they might feel, if it was a family friend or a paid caregiver who was involved in the abuse, really thinking through how we support the caregiver during this journey. The same goes for in nursing facilities, staff who might be feeling, this person, experienced this and I'm feeling some secondary trauma. So at the end of the day, what I want to say about why it's so important to have trauma-informed care in place is that trauma responses really persist even when that event can't be recalled. Even if that person can't articulate it, that trauma is felt from a very physical level. So we should really treat these maybe new behaviors, and I even hate to use the word behaviors, but these, new manifestations of this especially after a known assault, as a trauma response. These are not necessarily symptoms of dementia that we need to medicate, and sometimes that's our first line of defense, unfortunately. Next slide, please. So let's go back to Margaret. I've told you a little bit about what was going on with her. A few things. The aide really did an awesome job in documenting her observations verbatim. Here's what I'm seeing. This is what's happening from my perspective, and reported the same day. Actually reported to APS after consulting with her supervisor and the team. And so within that specific window of time, they were able to get her in for a forensic exam with a qualified provider who was able to, assess the situation. Come to find out, it was a family friend. The person that she was very reluctant when she heard her name or heard their name, it became a very inconsolable and screaming. That person was barred from the home. Her son really helped guide us in terms of the safety plan after he got over his initial shock of what had happened. Locks were changed. The family created a visitor log so they could better track who was coming in and out of the home. It was more structured in terms of visits. We were able to have the aide go in more frequently throughout the week to sort of help with this because she had built a rapport with Margaret. So the care was really adapted for her to also feel safe in this particular situation. And she started at a certain point during all of this, she started having a lot of fear around bath time. So we really, as a team, treated that as communication, not, quote unquote, dementia agitation. So we didn't necessarily focus on, oh, let's start a medication for this to treat this particular symptom. We understood that that was her way of communicating. And so we assessed it in that way and proceeded in helping her in a better way. And so I want to highlight here again that sometimes those individuals who are providing direct care are so critical because the aide's ordinary documentation that she did as part of her job really became this extraordinary evidence at the end of the day where we were able to, help Margaret's family file charges against this individual based on all the documentation that we had as well. So this was, a really good conclusion at the end of the day for everybody involved. And we were able to figure out, how to best serve Margaret and her new needs. Next slide, please.
Sam, are you okay with a question related to this slide?
Oh, yes, yes, yes.
Great. So we did have a question from Dr. Kara Kuntz. So is the same exam for Margaret completed in the ER or was it in the home?
Yeah, it was actually, we were able to get her into the ER for this. I do know in some states there are individuals who can come out to the home and do this, but we were not able to do that in a timely fashion because this is actually a person who lived in a rural community. But I have heard of that being an option for some individuals. It's just here in Kentucky, we didn't have that as an available resource at that moment in time.
Thank you.
Yeah. No, that's a
Kara,
great.
if there's any follow-up
Yeah,
questions,
did
let
you have
us
a
know.
follow-up question? Just
Okay.
let me know. So we can go to the next slide because I also want to quickly tell you about Frank, who is a person that I had worked with in a nursing facility. And this is where we get into the sort of harder direction of some of this, where the person with dementia is the person, potentially harming other individuals. So when I first started working with Frank and with the care team at his nursing facility, he had been living in the memory care unit at that facility for about 8 or 9 months, and he had frontal temporal lobe dementia. Staff had started reporting, he was sort of escalating in terms of his behavior. So sexual comments towards anybody around him who would listen. He grabbed a CNA, not necessarily in a sexual way, but more in an aggressive way. And that sort of escalated to where when I was completely brought into the situation and learned about all of this to help consult the night before, Frank was found in the bed of another resident who was a woman with advanced Alzheimer's disease. who the facility felt like, okay, this person can't consent to whatever has happened here. And she was also crying and very distraught. The daughter of the other resident was really demanding that Frank be kicked out of the nursing facility, that he be arrested. She was very distraught. Frank, I failed to mention, was also married. His wife lived out in the community, and she was also devastated. This is not like him. He's never had any situations like this. And so, one of the things I had to ask myself as a practitioner is, who's my patient here? And how do I figure out how to navigate, Frank, the other resident, both families, the staff was also very distressed about this. So there was a lot that went into all of this with Frank in this particular situation. It was very complex. But before I tell you what happened completely with Frank, let's go to the next slide. I think it's really important for us to understand when we talk about this from this sort of frame of reference, where sometimes this sexual abuse or sexual inappropriateness is a symptom. It's not always the intent of the individual, right? But it does cause real harm, and we have to honor and understand that. So let's think about this. Sometimes we have individuals where they have disinhibition because of the damage to the frontal systems, which sort of remove what I call the brakes of the brain, right? So they don't know when to stop or what's it appropriate. And that can be especially true for individuals with frontal temporal lobe dementia, for those of you who have worked with individuals and understand sort of the physiology and neurology behind that. Often there's also this misidentification that occurs. So Frank, in this situation, may have truly believed that the other resident was his wife. So he might view this behavior as affectionate, but in reality, it wasn't for her, right? Also, and I know that you all have had a previous Project Echo session about sexuality in older adults and sexuality in persons with dementia, but we can't, discount sort of an individual's unmet needs, loneliness, boredom, that need for human touch and intimacy. That doesn't end when a person becomes diagnosed with Alzheimer's disease or another type of dementia. But there's this tension that sort of, is very apparent here. The law sort of assumes that there's intent there when these situations happen. And dementia has sort of erased that intent to a certain degree. But we also have to, on the flip side of that, understand that the other person, the impact that it has on them. So we know that, even though his intent might have been pure, or he just was trying to, really be affectionate towards the other resident, or really felt like he loved her, that's not how that was perceived by her. So naming the neurology behind all of this is not necessarily excusing the harm. I do think it's something we need to be aware of. Next slide. And largely what I always suggest in these situations is finding the driver before fixing, choosing the fix. So we want to rule out acute causes for this type of behavior. We want to chart the pattern, right? Is it targeted towards one person or multiple people? What time of day are these incidents happening? We want to name the behavior. Is it intimacy seeking or misidentification? Each really points to sort of a different way that we can intervene in these situations. And we also want to not dismiss, again, sexuality as part of this. So assessing capacity and consent both ways is really, really critical. Not all sexual expression is abuse. Intimacy is a right of individuals as well. But the question that really comes into play here is, can both people in these scenarios understand, agree, disengage when they need to or want to? So it really does call for a more structured assessment in place, not really a blanket ban. Now, with Frank, this was a little bit of a different situation because it seemed on the surface very clear that the other resident was distraught by whatever had occurred overnight. So we really have to be tactful in the way in which we handle these situations and really think about what's in the best interest of the individual. Next slide. So in the moment, we really want to and need to protect both people. For the person who is harmed, we really want to think about what does that calm separation and medical evaluation look like, notifying their family, notifying their physician, especially, this was a nursing facility situation, so we had a medical director that was involved. And we want to remember their trauma is real, even if they can't recall it, much like Margaret. She couldn't give us specifics of what happened, but we could tell that this was something that was very traumaful for her. Um, then for the person with dementia, we want to redirect calmly, matter-of-factly, no shaming, scolding. Confrontation's going to be sort of lost in these situations and sometimes only escalates that person's behavior. We want to make sure we increase supervision while we assess what's going on. And we do have to report. We had in this particular facility, we had an incident reporting sort of chain that went up to various levels. And to just understand that this person has dementia does not waive that reporting obligation. And we definitely don't want to conceal when these things happen. That's really where facilities get into trouble. Next slide. Um, so then we get into, thinking about care planning and sort of what this, again, getting into that legal gray zone, right? So on care planning, we really want to focus on environmental first, room placement, line of sight supervision, structured engagement. And this did come into play with Frank as well, really meeting that underlying need that he had. And that's sort of why he was expressing himself inappropriately because he really didn't know how to articulate those needs. But then knowing on the legal side, we still had to report this and figure out what to do. Next slide. So how did Frank's case resolve? We did have to file a report. We filed it within the same day. Obviously, I already told you the other resident's daughter was notified, but his family was notified as well. We were able to help the other resident get a medical examination, figure out some sort of comfort plan with her that was integrated into her care plan, monitoring, really naming that harm, not minimizing it. Then with Frank, really looking at, okay, what's the contributing factor here? We looked at a number of different things. One, we looked for a UTI, we looked for medication changes. We did realize that he had recently started a newer medication. And so it had been also tapered very recently. So we were trying to figure out, was this causing this? Also, we started documenting the time of day that these incidents were happening with him. And it tended to center around 6 to 8 p.m. So at this particular facility, that's when there were less activities going on, less engagement. Staffing was lower during this time too because it was during shift change and people were documenting or, just coming on to shift. So we figured out, structured evening engagement with him, relocating rooms so he wasn't in proximity of the other resident. And then also figuring out 15-minute checks with him during those windows of time where this seemed to be a real issue. And over time, we were able to keep documenting this and realize that a lot of these things we put in place were really helpful to Frank. And so we didn't have further incidents reported. So we were able to really navigate that accountability piece with that compassion piece together at the same time. And I think that was really, really important in this scenario. Next slide. So again, just to highlight some of these things as it relates to, if a person with dementia is harmed, you're sort of on this left-hand side. We want to focus on safety, reporting, documenting, trauma-informed care. If the person with dementia caused harm, focus on the right side. Protect the person harmed. We need a report. Assess for anything medically that's going on with that individual that could be contributing factors. Intervene with environment and sometimes engagement first before we go to, medicine. And, in resident to resident incidents like this, everything contains, every situation where it's a behavior that is, from a person with dementia who is causing harm to another resident. We've got both, kind of scenarios here. And so it's really important for us just to be aware of those mechanisms as well. So You can go to the next slide, sorry. So a few things I also want to highlight is to conclude this particular part of our talk. Behaviors communication, let's not forget that on both sides of the incident that's occurred. We want to make sure we report facts. We also want to make sure that we understand that memory loss is not immunity from trauma. It doesn't protect us from those physical ramifications of trauma, but it doesn't prove guilt or innocence in certain situations. We really want to protect the vulnerable without discarding the person with dementia. And, really making sure that we understand that it really does take a team, whether it be, thinking about from an interprofessional standpoint, medicine, social work, community health workers, APS, law enforcement, family, the person involved in this as well. So really, really important that we work together in these scenarios. Next slide. And I believe this is my last slide. I wanted to sort of open it up and give you some resources here to say that, you may have experienced this or a similar situation. So if you want to um, really focus in on, things that you've had happen as part of your work out in the field, what got missed, what do you wish had went differently in these scenarios?
Sam, fantastic. Thank you so much for all of that information. I'm going to open up first up. I see that you had a question. Why don't you kick us off, Abhilash?
Yeah, hi. So I'm a psychiatrist who works in nursing homes, and they say we've tried non-drug interventions. There's no medical causes. Uh, Nothing is helping. So, any suggestions what I should say?
Yeah, I have experienced this where I think that sometimes we try one thing and it doesn't work. And then we're like, okay, well, let's immediately go to medications, right? And sometimes it me in those situations what I haven't covered, and again, I'm a social worker, not an MD, I'm not prescribing, so I tend to go to the more social behavioral intervention route first off, and that's probably my bias. But what I have found is that a lot of times the people who are immediately saying, okay, we need an, antipsychotropic medication in this situation, or we need this. It's because we've not all come together and had a conversation about the full scope of what's going on with the individual and the behavior. And a lot of times there's spotty documentation, unfortunately. So we don't know, let me use Frank as an example. We weren't doing a really good job of documenting those inappropriate sexual comments that he was making and when they were occurring. It was just sort of a thing that had gotten passed down from one CNA to the other, to administrators that he's doing this. But we didn't identify that it was happening more between that window where we were having staffing changes, where we didn't have programming going on, where it was sort of that lull. And, he was seeking attention. It took us, till after this major situation occurred, quite frankly, for us to start doing better in terms of documenting that piece and sort of understanding that. So I always encourage people to make sure that every person who's working with that individual, they're documenting and then somebody's reviewing it to look for patterns because a lot of times there are patterns to these types of behaviors. And not just isolated patterns, sometimes it's very consistent once we start looking at the documentation. So that would be my first line of, thinking.
Yeah, I can tell you they'll show me they have to track data before we give meds. So
Hmm.
they show me the incidences, they show that the staff are refusing to care. In fact, they are threatening the family members that they'll have to take them somewhere else. And no other facility is willing to take them because of this.
Yeah. Yeah. And is it a sexual,
Yeah,
um,
they are
yeah.
physically touching the staff in
Yeah.
areas that are obviously sexual, and they are sometimes doing it quite roughly, and
Hmm.
nothing is really helping.
I guess I would also go to, is the person receiving any appropriate touch? So what I mean by that is that, we all need to be touched, right? And so sometimes people react because inappropriately because they're not getting that part of their cup filled, so to speak, to use a sort of anecdotal thing, but things like appropriate hand massage or appropriate hugs, things where they're appropriate in nature to help that person, feel that connection with somebody else. And I think that, again, especially when it's sexual in nature, I always go to, is that person, responding inappropriately because, again, they have dementia and they don't know how to articulate, I'm lonely, I'm sad. I miss being hugged, I miss being touched. And so they're responding to it those around them inappropriately. So maybe things like appropriate touch, like especially hand massage, is really a great way to do that.
Thank you. Yeah, I've diagnosed my patients with touch deficit disorder, but then I get fired when I don't prescribe meds. So anyway, thank you.
Oni, I see you're unmuted. Were you wanting to chime in as well?
Oh, I appreciated Dr. Desai's question about when there really is. I work in a veterans home, so I've got, predominantly male veterans, predominantly female caregivers.
Oh,
And,
yeah.
you know, um, wonderful presentation, but like really addressing that what happens when it's consistently happening, because we still need staff to show up for work too.
Hmm.
And when they're driving to work and they're gripping the steering wheel because last time they went to care for this person, he tried to grab them or he propositioned or whatnot. And making a clear distinction between people who have advanced dementia and people who just might be sexually aggressive by nature
Yeah.
is a good start. But I just smiled and unmuted when talked about the touch deficit, because
Yeah.
as we talk about oftentimes on these echoes, all behavior is a form of communication. And well, what are people trying to tell us is sometimes it's I'm lonely, or I don't quite recognize that you in here in my room taking my pants off is not a proposition. It's just twitch.
Correct.
But that touch deficit, and I don't have any foolproof solutions, but I definitely smiled when he said that.
Yeah. No, and I totally appreciate this part of the conversation because I do think it's so difficult and there's not always a clear, like, if this, then this, sort of thing. And that's so unfortunate because a lot of times we do want to do things that are so clear cut. And sometimes it's throwing that proverbial spaghetti up against the wall and seeing what works best for that resident or that person who has dementia. And also, this is something I didn't say that I probably should have added, is that a lot of times those individuals who are doing the direct care are the people who are at most risk sometimes when it is a person with dementia who is, behaving aggressively, whether sexually or not, right? Sometimes we have individuals who are just physically aggressive for one reason or another. Making sure we take care of those individuals who are doing the work. Self-care is really, really important, and for them to be able to have those conversations and also helping. I've worked with so many CNAs and direct support staff who, because their training and education had been limited about dementia before they were thrown into a memory care unit and working, they didn't quite understand what it was like working with a person with dementia, especially when they have these types of behaviors, and they were not equipped to how to deal with those situations in that moment in time. And that only exacerbated the situation, right? Because they weren't equipped and the person with dementia doesn't know those boundaries. So really thinking about it from those both ends and making sure that we're taking care of those people who are, again, the critical backbone of, a lot of the work, who don't always get that recognition as well.